So next topic is acute pancreatitis. It's V3. 22-year-old woman complains of abdominal pain radiating to her back, nauseating and vomiting. On examination, she is tachycardic, tachypneic, and in pain. The urine and pregnancy tests are negative. The white cells are 15, LFTs are mildly deranged, and the amylase is 1275. How would you manage this patient? So this look like she has acute pancreatitis. I would resuscitate her with oxygen, IV fluid, and analgesia. Insert a urinary catheter and consider NG tube if antiemetics not working or she is vomiting. I would review her in 1 hour to assess the response to resuscitation. And if she remains clinically unwell, then I will contact the HDU to escalate her care to the level 2 bed. Following resuscitation, she rapidly improves, and PCA, patient control analgesia, controls her pain. What is the likeliest cause of her pancreatitis? The commonest causes of pancreatitis are gallstone disease and alcohol, but there's a mnemonic called I get smashed. I idiopathic, G gallstones, E ethanol, T trauma, S steroids, M mumps and malignancy, A what is A and S scorpion, H hypercalcemia, hypertriglyceridemia, E ERCP, D for drugs. I forgot about A. So I would initially request an ultrasound scan to elicit the etiology to look for the gallstone. If this was negative, history did not suggest alcohol intake, I would measure her serum calcium and cholesterol levels, especially the triglycerides, and look for the drug causes, for example steroids. What scoring systems are used in the pancreatitis and how useful are they? There are a lot of scoring systems. So we used IMRI scoring system in UK on admission, which is P partial parietal less than 8, age more than 55, neutrophils white cells more than 50, calcium less than 2, R raised enzymes which are renal function, urea more than 16, and then pancreas E enzymes, raised enzymes, LDH more than 600, AST more than 200, and then is A and S albumin less than 32, and S is the sugar more than 10 millimole. So, and CRP is also an independent prognostic factor more than 150. So this is IMRI score, which is used on admission, and then is the Ranson score, which is completed 48 hours after admission, and the other one is Glasgow criteria, which is used for alcoholic pancreatitis, and then it is the Atlanta classification: mild, moderate, and severe pancreatitis. Mild, no systemic failure, no local or systemic complications. Moderate, in which organ failure is persistent but which settle in 48 hours, and severe pancreatitis, when it is organ failure which didn't settle in 48 hours. And then there's the Apache acute physiology and chronic health evaluation 2, Apache 2, and these scores sometimes fail to identify, and patient can deteriorate on the ward. What is the role of antibiotics in pancreatitis? Currently there is no evidence of antibiotics in pancreatitis unless there is concomitant cholangitis or cholecystitis, or patient develop any line sepsis or urinary sepsis or lung sepsis. In these, antibiotics should be given as per protocol. How and when would you feed this patient? I would allow the until feeding a patient is well. If it's vomiting, we can wait until, or we can start NG feed and NG feed. So enteral feed is preferred than the TPN because it protects, it keep the integrity of the gut mucosal barrier intact and helps to counteract the catabolic state better than the TPN. What are the potential complications of severe acute pancreatitis? So these are divided into the local and systemic. So local complications are necrosis of the pancreas, sepsis, walled off necrosis, pseudocyst, disrupted duct, pseudoaneurysm, bleeding, and diabetes late. And systemic complications include again sepsis, acute respiratory distress syndrome, acute kidney injury, DIC, multiple organ failure, and the death. And this patient continues to deteriorate and is transferred to ITU on day 3. A CT scan on day 5 shows 60% necrosis and a large pancreatic collection with gas pockets. How would you treat her? So step-up approach as in the guidelines given in Panther and tensional trials. So initially ultrasound guided and then endoscopic drainage and necrosectomy. If there's no facility, then we can do radiological guided retroperitoneal drainage, which allows the tract to mature, and then proceed with the video assisted necrosectomy. If all these measures fail, then it's the open necrosectomy. A single patient was admitted in the same day with gallstone with pancreatitis and did drain LFTs, which improved 24 hours later. How would you treat her gallstones? So ideally, I would do her a laparoscopic cholecystectomy with on-table cholangiogram. If this was not possible because of the logistic reasons, then I would aim to remove her gallbladder within 4 weeks of the discharge. I would request an ERCP only if she had evidence of cholangitis or obstructive jaundice. How would you treat a pseudocyst? If they are asymptomatic, leave such as such. Otherwise, they can be drained endoscopically, laparoscopically, radiologically, and the open cystogastroscopy. Thank you.